everyone. Thank you so much for having me. I really appreciate the opportunity. I'm going to talk about ventricular assist devices. So I'll just get started. Just know that I have no disclosures. Any of the patients that I have pictures of on this talk have signed media releases. So just to start, why we do ventricular assist devices, I always lead in with a quick slide on what heart failure is and what it means to us. And so there's many definitions out there about heart failure. So you may have heard it called different things and defined different ways, but the Action Heart Failure Committee, and I'll talk a little bit about the Action Committee later in the talk, defines heart failure as a clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection. Symptoms that are most common that these patients present with include difficulty breathing, difficulty tolerating their feeds, and decreased activity. And this is important, a definition for me to bring up because a lot of the historical definitions really applied specifically to adults. And that's a problem that we have in the pediatric world where a lot of things are extrapolated. But thankfully, because of a lot of collaboration among the community, we now really focus on how do children present or teenagers present with heart failure. And there's a lot of different causes of heart failure, again, very different from adults, and that's becomes important in how we treat and manage these patients. Some of the more common ones are congenital heart disease, cardiomyopathy, myocarditis, or cardiotoxicity, and that's heart failure that is caused by different medications, such as like chemotherapy, can also cause this disease. And so what is a ventricular assist device? And that's really the meat of the talk today. It's a tool that we use to treat heart failure. So if a patient or a child or a teenager or a baby is having persistent symptoms of heart failure and need more than just medical management, we start to talk about whether or not a ventricular assist device is the right next step for that patient. The important thing for us to remember as clinicians, and also as we have ongoing discussions with families about whether or not this is something that's the right next move for their child, is important to know that we don't have to know what the end point is as far as where we're going. Is the patient's heart going to recover? Are they going to need a transplant? Is this going to be short-term or long-term support? And so those answers are something that we discuss early on, but we may have to change paths. So we may put in a device in order to support the child, and then we're able to take the device out. Or most likely, which is the most common, is that they do undergo heart transplant in the future. But we don't always know, and we always try to see if the heart will recover. And that's something we can always continue to reevaluate and see what path this patient is going to take, and that may change. And so why do we think a patient might need a ventricular assist device? So if their heart failure is not responsive to medical management. So what do we mean by that? So if we're looking at a child or a teenager who has symptoms that are prohibiting them from growing or rehabilitation with physical therapies or functioning on a daily basis, and they're getting too short of breath when they get up out of bed, or they're not able to tolerate their feeds because the blood and oxygen that the heart is pumping to the stomach isn't enough for the digestion system to be able to tolerate those feeds. So they're having a lot of vomiting, and we're not able to get to goal feeds to get them growing. And then other end organ things that we look at are the liver. Is the liver functioning well? We can check that on multiple different lab tests and imaging tests. Are the kidneys working well? Are they able to breathe on their own, or are they requiring a lot of support in order to support their breathing, and their lungs aren't working well? So these are the things that we're looking at. And if we're escalating medical therapy and we still see these signs, that's when we are starting to have the conversation about next steps and potentially considering a ventricular assist device for that child. And so what are the challenges of ventricular assist device therapy? Well, unlike the adult population in pediatrics, we have a varied age and size range of the population. So we're talking about babies just after birth, days old, all the way up until teenagers. We're also talking about different causes of heart failure. So They could have all the different there's all these different causes that we talked about in the beginning: congenital heart disease. Do they have a cardiomyopathy? Were they on chemotherapy or required a medication for another reason and now have effects of that medication on the heart? So different reasons could cause different types of devices that we would use for these patients, and different strategies of how to put the device in. They have complex anatomy if it's a congenital heart disease patient. So there's varied types of congenital heart disease. And even within one type of congenital heart disease, there's varied anatomies within that. So working closely with our surgeons and our imaging colleagues to define exactly what that anatomy is and how we would put that device in that patient safely without having any obstruction to flow is a whole nother challenge that we come across. And then difficult to predict when a child needs a ventricular assist device. Children tend to decompensate quickly because they compensate quickly for a long time until they can't anymore. So adults can tell you they're not feeling well. They can show you signs of changes in heart failure. And for kids, they're really resilient. So they may be running around and look well and have just very mild or minimal signs or no signs until they're so sick that they need very aggressive treatment to make them better. So kids are different, and there's all different reasons why kids might need a ventricular assist device. And so because it's not common and we don't see high volume of these patients, it's our job to work together and learn from each other and do the best that we can to share our knowledge amongst our colleagues so that we can do the best that we can for these kids. And so heart failure affects all ages. And like I was just saying, there's a small number of patients treated at each hospital. So you may have a handful of infants on one side of the country and then some young children and school age and young adults within an institution, but the volume is low. And so we really need to share our knowledge across the country and across the world to learn from all of these different types of patients and all these different types of heart failure and all these different types of treatments that we use for these kids. And so I'll go briefly on the different device types. So we talked about what a ventricular assist device does, which is helps the heart pump the blood and oxygen to the body so that the child can grow and have all of the blood and oxygen to all of the organs that they need to function and eat and tolerate rehabilitation and be able to live as normal of a life they can with their heart failure. So if they're unable to do that, we can put in a device that will help their heart enable them to do all of those things. So the different device types that we have right now for children, a Centromag or a PediMag, that's a continuous flow device, meaning it's just a propeller that's circling around that's pumping the blood to the rest of the body. That device can go in any sized patient, so anywhere from a small infant all the way up to adults. But the patient needs to stay in the hospital. And if you can see sort of this is a depiction of what the device looks like. They're attached to this machine, and that they're going to be attached to that machine until they come off of that device. Another device that we have that can be used in small children all the way up to bigger kids is the Berlin X-Core. So this is a pulsatile device, so it's pumping rather than a continuous flow device. And the benefit of the Berlin X-Core is that the cannulas that can carry the blood from the patient to the pump and then from the pump back to the patient is designed to be more durable or long-term. So this device can be used in babies and adults all the way through to adults, but also the patient at this time until there's newer technology also needs to stay in the hospital for the duration of the time that they're on the device. And as a lot of you know, if you're waiting for a heart, it could take months to years. So these devices, while they are able to be used in children and infants, they keep the patient in the hospital. So as a patient gets bigger, there gets to be more options. And that's because a lot of these devices are initially designed for adults and then extrapolated to kids. So a bigger child may have more options as far as what support devices they can use. So a HeartMate 3 is a device that's more implanted into the body. There's still a part that comes out and connects to batteries or the power source. But this is a device that the patient can go home with. And a lot of teenagers or adults can stay on this for years and years and years. And a lot of older children and adults may not undergo transplant right away or may not want to for various reasons. That could be a medical reasons, family preference, and so they can live on this device at home and function well, and it supports them. But unfortunately, this device, though, has better options, isn't small enough for our smaller patients. And then two other devices to mention. The Impella is also a device that's only for bigger kids or teenagers or adults and is a temporary device. So this is something that they don't need surgery for. It can be inserted in a procedure like in a cardiac cath lab and can support the heart, but only temporarily. So this is something if we expect recovery or we're trying to decide what device would be best next for the patient if they need one. This can give us a week or two, usually is the average time frame that we would use this, but it's another option for bigger kids and teenagers. Again, the patient would have to stay in the hospital for that. And then the last one is a total artificial heart, which is also bigger kids, teenagers, adults, that if there's multiple reasons why taking the heart out and replacing it completely would be beneficial. This is another option for that. So intractable arrhythmias, the heart's beating in a way that's causing it to not function well with a pump, or there's large blood clots in the chambers of the heart. There's different reasons why we would consider this as a device option, but again, only for bigger kids. There's different ways to support these patients. So left-sided heart device, right-sided heart device. If there's congenital heart disease and a patient only has one ventricle, so single ventricle assist device, we can use it that way as well. And then a BiVAD if a patient has two ventricles, two sides of the heart, but needs support on both sides, we can do that as well. And so many cardiac therapies are not studied in pediatrics, and the results are extrapolated to adult studies. So this is a lot of the challenges that we face in the pediatric world. And that can be with medications, monitoring and rehabilitation, technology and systems, the ventricular assist devices, and also transplants. And many times we use devices for adults and our children. The devices that we use for adults we use in our children, and that's because that may be the best option for that patient, and we know how to make it work for that child, but it wasn't necessarily initially designed for that child. And this happens, like I said, in many different things in pediatrics, but specifically talking today about ventricular assist devices. Because pediatric devices, the patient has to stay in the hospital. This on the left is the Berlin X-Core that I was talking about a couple slides ago, and on the right is another device that's no longer on the market. She had an HVAD, but the HeartMate 3 is the similar concept where the patient can go home with the device, but it's only designed for bigger kids or adults. And so looking at some of the outcomes also, while we have these options to help support the patient and maybe the best thing for them if they're struggling to thrive with their heart failure on just medical therapies, but there are adverse outcomes that we know of and do everything we can to manage, but unfortunately still happen. So stroke is the one that worries us the most because it can affect the child's brain function if they have a stroke, and that can be with a blood clot or a bleed. So a lot of these kids are on all of these kids have to be on blood thinning medications while they have the device in place. Bleeding events, infection events are other things that we look at. The current average incidence of stroke is upwards of 11% in the Berlin heart. It used to be a lot higher, but it still is unacceptable as an adverse outcome. And while 11% is a lot, not all of those are catastrophic. They may be smaller or mild, but still unacceptable, and something that we as a community are working on vigilantly to try to improve these outcomes in these patients. The HeartMate 3, on the other hand, which is one of the adult devices that you can go home with that only fits in really bigger kids, teenagers. So the median age of a HeartMate 3 in pediatrics is about 14 years old. So the younger kids are too small for this device. Has a 2% rate of stroke in patients. And then this was several years ago. It's actually been a little bit better. And there's been some years where, as a community, all of the data that we pull together, which is almost every institution that does these devices, contributes data. We've had no years where we've had no strokes on HeartMate 3. So a much, much safer device, but not an option in our smallest patients, unfortunately. And so I mentioned a bit, but the problem is that despite the prevalence of pediatric heart failure, it's underfunded and understudied. Cardiac devices and medicines are not developed for children. And there's inequalities based on where the patient lives. If you live in an area or close to an institution that has these advanced cardiac therapies, you may have access to them. But if you're in an area where there's not an institution and you live further, that's a big barrier to care and a big challenge for patients. And these barriers lead to an increase in pediatric heart failure related mortality, more hospitalizations, more adverse events. And we don't always have the right treatments. Most heart failure medicines are not approved for pediatrics. We use them as we learn more about them, but they're not designed initially in the early stages of development for children specifically. Most of them aren't. 1 in 5 children with heart failure will need a ventricular assist device or a transplant, so medical therapy won't be adequate for those patients. Half of children needing a VAD are too small for advanced continuous flow technology, so they go on these other devices that we have that are life-saving, but have a higher risk profile as far as stroke, infection, bleeding, and they have to stay in the hospital and they're unable to go home. And the best therapies are not always available due to relatively small patient numbers, lack of economic incentive for our industry partners, burden of data collection, and suboptimal awareness of the problem within the community. So we have these problems of complex treatment selection, complex decision making, complex support strategies, and complex patient management, and inequality of care. Since they aren't always designed for children, treatment options may also depend on the patient location. And so if we only have small volumes of patients to learn from at each center, what do we do about that? So we are working on a solution, and we have made a lot of progress within the community of these care teams that take care of these kids. And how we've accomplished some of the progress that we've made is through a learning collaborative network called ACTION, which is Advanced Cardiac Therapies Improving Outcomes Network. And this network provides a community that works together to improve care practices and critical outcomes for patients with cardiac disease in underserved populations, which are all of these kids really, because we don't have perfect devices. And so we want to serve them better. And so we look at quality improvement and research on how do we do this together. And so in 2017, Action was started, and it's grown to over 60 institutions now to collaborate on patients with heart failure. And this collaboration unites patients, families, clinicians, regulatory bodies, researchers, and our industry partners as well. And so what have we done so far? This learning network was designed to bring everyone together, patients and caregivers, providers, and institutions. We want to pull in our research and our technology to see how we can improve outcomes in our patients, regulatory and industry. So we all work together with one goal in mind to improve outcomes for these kids. And so the focus has been on real world data. A lot of networks or registries take time to collect the data and then analyze the data and then put that data back into the community in order to make a difference. And so our focus is to really have real world data in real time. As we learn from each other, we can use that data to improve things and take away the barriers in time to improve these outcomes as we learn things from each other. A collaborative community is extremely important. When we only have a handful of these kids at each institution each year, we want to learn if there was 100 kids across the network, what have we learned by taking care of those 100 kids instead of just the 5 or 6 or 10 kids at the institution we work at? innovation is so important. As we talked about, the devices available for kids aren't good enough. We want them to be better. They're good and they're life-saving, and we use them and we need them and we're thankful for them and we're learning how to use them better, but we also want better devices. We want to look at our quality improvement measures and see how we can improve outcomes, looking at all of the different quality measures, as well as research and clinical trials. Clinical trials are, children are underrepresented in clinical trials, and so we're doing more to run clinical trials specifically for children to improve their outcomes. And then education. There used to be no standardized education across providers who took care of ventricular assist devices in children. And so we've worked to make education available to everyone, families, patients, and our providers. And we spread that education across the board to anyone that needs it on our virtual platforms. So we've had success in decreasing adverse events. We've had success in collecting real-world data and obtaining FDA labeling for pediatric devices, providing post-approval surveillance for FDA-approved devices in children, creating patient and provider education, innovating with wearable technologies. So this comes back to the rehabilitation aspect of it. So how are they doing, and what feedback can we get based on how we're supporting them? And then launching a prospective pediatric device trial through this Action Learning Network and through our industry partners, so that we can look at how we can improve for children specifically and not as a secondary thought after the adult trials take place. And so we collaborate often. If anyone is involved in Action, you may know this. If you have providers who have mentioned it, we talk to each other all the time. We meet in person multiple times a year to see how we can collaborate with each other, but we also are constantly talking virtually, and it's a huge network for support. And if you have a child on a ventricular assist device, you may get the advice of the entire network. So we have a platform to have conversations about clinical questions and clinical scenarios that aren't following the trajectory that we may have expected, or there is a challenging case for how would you support this child, and we can pose those questions to the network and have feedback from other providers and other institutions. And so hundreds and hundreds and hundreds of conversations take place each year, announcements from the network to let us know what's going on, what updates are happening. So it's a really, really great collaboration. There was no pediatric specific VAD education before this network. There was no specific provider education either. So there are now pediatric facing education materials that have been created in collaboration with providers, patients as well. Industry have also worked with us on this. There's an e-learning website, myactioneducation.org, that you can go onto and learn about the different devices and about heart failure. And now we have the framework to expand education to other patient populations. So we're going outside of just ventricular assist devices and doing education for other entities, heart failure, muscular dystrophy. There's a lot of other subdivisions within Action now to improve education across these rarer diseases, but hugely important, and how we can come together to do the education that we need. So we plan to create necessary education materials. As more devices are approved, we'll create more materials. So it's an ongoing process. We've also created harmonization documents and multiple other publications in different journals to standardize how we're taking care of these kids. So if we have multiple institutions that come together and we say, I am using these types of medications for blood thinning medications for my patients, and someone else is using different types, and we see the institutions that are using this regimen are having better outcomes. We look at that data, we analyze that data, we have conversations among the experts, and educate and standardize. Now that we know this works better, let's create a harmonization document so we're all doing it the same way and we all know what is the best way to do it. And so we're constantly, that's the real world data that we're taking to each other to learn and standardize how we take care of these patients. And we've also had devices, medicines, and trials. There was only initially one VAD that it was approved for children, which was the Berlin X Core, and heart failure medicines weren't studied in industry. So we decided to collaborate with FDA and industry, use ACTION real world data to apply for expanded labels, and then use the ACTION registry to launch a prospective device trial. And now there's two approved devices for use in kids. The HeartMate 3 was added with a pediatric labeling, and we're also doing a clinical trial for a pediatric VAD device. So this is the labeling for the HeartMate 3 that was in collaboration with Action and Abbott. And then the Berlin Heart Active Driver is a prospective device trial to be done that is in progress and ongoing to improve mobility and rehabilitation, and device that's they'll be a little bit less tethered down with the driver with the Berlin X Core with this type of device. And so there's benefits to it, more training, more education, insurance and hospital acceptance as we get more FDA approvals. In the future, there's other devices that are in the early feasibility stage. So they're really still in just like animal studies and adult trials. But Brio Health, Brio VAD is a smaller left ventricular assist device that could potentially be used in children in the future. Vivacor is a total artificial heart with newer technologies. Corvion is another one that's being worked on that's a totally implantable device, so would eliminate or minimize the risk of infection and other things. And they wouldn't have external batteries, so a little bit more helpful as far as functioning on a day-to-day basis. But we need to do more. We're working on it, but it takes time. But every day, I think we have a really nice network to continue this collaboration, to continue improving outcomes, and to just make it better for these kids. So I encourage you to ask questions, write them down, talk to your care team. We as providers know that you know your child better than anyone else, and we are here to partner with you. Every child is different, so factors influencing the decisions on you or your child's journey may differ from others, but it's still helpful to talk and learn from each other. And use your resources, forums like this one with transplant families or the Action Network, and your care team, and ask those questions. Thank you.
Hello, and thank you for joining us today. We're really glad to be with you. I have a few questions. Dr. Perry was not able to join us. She's on service and she's helping families, which of course takes priority. So we are so fortunate to have her colleague, Katrina Fields, with us. Katrina, can you tell us a little bit about what you do with the VAD program at Cincinnati?
Absolutely. So I am a VAD coordinator at Cincinnati Children's. I've been here at the institution for 12 years and been a VAD coordinator going on 8 or 9. So I am integrally embedded in the day-to-day life of the VAD patients. I follow them from implant and really kind of do education before implant in the OR. I see them in the ICU and step down, and if they're able to be discharged, I go with them and see them in clinic after discharge. So the entire journey, I stay with the patients, and they're kind of stuck with me until they get transplanted.
We love that. I mean, we depend on our nurses so much. I swear you become part of our family through this process. So thank you for doing what you're doing. I have just a couple of questions for you from our audience. How does having a VAD affect a child's priority on the transplant list?
Great question. So it depends on the kind of baseline etiology of what's going on. As you know, the highest status is 1A. And for patients that are inside the hospital with a ventricular assist device, i.e. Berlin, Centromag, and they will be promoted to 1A status. It doesn't, for those patients that are already 1A, it doesn't increase their status or change their time on the list. But for those who are 1B, like on Nornone or if they're at home, getting a ventricular assist device inside the hospital and staying inside until transplant will make your status a 1A.
Thank you so much. That was actually very thorough and comforting, I'm sure, to so many. I have one more question for you, and this one I've wondered about myself. What happens if there is a VAD malfunction at home? I know that more and more families are taking them home now. What should families do?
So the devices that can go home, as Dr. Perry mentioned, are typically the HeartMate 3. If you were a part of the generation that was the hardware was available, that was in a device that can go home, and Syncardia. We don't often send Syncardia patients home because it gets transplanted pretty quickly, but they are eligible to go on a Syncardia device. So I know at our institution and many other institutions within who are part of Action, we take education for families very, very, very seriously. There is at least an 8 to 12 hour education on the device. So we spend multiple hours going over what the device does, how it works, what to look for, emergencies and troubleshooting. I know here we do a simulation with families. So we take them to a room or take them outside. I will mess with the device and on a mannequin and set off alarms and ensure that families know how to effectively troubleshoot. We have a 24/7 emergency hotline that can get directly to a VAD team member so that you can feel comfortable with any troubleshooting or emergency issue that happens at home. So we're very, very hands-on. I always tell my families this, I don't want the first time you hear alarm is when you're at home. I want to make sure that we have simulated and gone over every possible scenario to make them feel a little bit familiar with the process of having emergency happen with a VAD at home.
Thank you so much, Katrina. I was also answering a question on the side. It's a great question. They wanted information for Action. I know you mentioned Action.
Yes.
It's a fantastic resource. Can you tell us a little bit more about the Action Learning Network before we go and leave our audience?
Absolutely. Action is a fantastic organization that collaborates with centers all across the nation. And specifically for families, we created a whole website, reading material, books, anything that you can want to get information on ventricular assist devices in pediatric population. We found it so difficult to find any credible information and up-to-date information for families that are just wanting to go through Google and try to find things. So we built this whole entire platform for families to have adequate, up-to-date resources specific to pediatrics. I think it is myeducation.org. And I'll send you the link, Melissa, and you can feel free to peruse and browse and find more information, not just about VADs, but for heart failure, specific heart failure function and questions that we may have. So it's a very comprehensive website and resource for families that just want some good information.
I encourage everyone to go check it out. They actually have a booth in our expo area, so check out. We've got all the links for them on social there. They're always looking for recruits. They're very patient and family-centered care model. So if you want to join in to some of these discussions, they treat patients as peers, and it's amazing. I encourage you to do so and check it out. I am also involved in Action. I think it's the best thing ever. So thank you, Katrina, for taking time with us today.
Absolutely.
We're so grateful. With that, I will sign off. And thank you everyone for joining us today, and stick with us. There's still a lot more programming that's wonderful to come. Bye.